Well, yeah, I can do that. And so this is a 30-day supply. This is what they take for a year. For 1 month to maybe 2 months, it's the whole kit. And I'll go through each one of these as to why, but one of them is vitamin D. It's got the micellized vitamin D in it. The packs don't have the micellized D. They've got 5,000 units of regular vitamin D in it. But you've got to get their levels up to adequate to maintain at 4,600 or 5,000 units. You've got to get them up there first. How do you do that? It takes a bottle, maybe 2 bottles of this usually, to get them up to adequate levels. So we'll talk more about that as we go along. So, oh wait. Yeah, well, how did that get there? Okay. Well, the third one. The third antibody in this screening for intestinal permeability, for antigenic intestinal permeability, is lipopolysaccharides. Antibodies to lipopolysaccharides. Lipopolysaccharides, LPS, are the remnants of gram-negative bacteria. Right? It's not supposed to be in the bloodstream. If you have antibodies to LPS, it's in the bloodstream. So the antibodies are fighting the LPS that's gotten into the bloodstream. LPS molecules are at least 60,000 Daltons in size. How'd they get there? If the patient doesn't have septicemia or an oozing wound somewhere, it came through the gut. There may be some other place it comes through, but the vast majority of them will come through the gut. Right? So if you've got antibodies to LPS, you got a major problem. And there are papers now showing, Michael Mays is a psychiatrist in Belgium. He's got about 160, I think, papers that he's published so far. Really smart guy. And he measures cytokines in his psychiatric patients, gets the cytokines down, the inflammatory cytokines, and he heals them from their schizophrenia, or their chronic fatigue, or their fibromyalgias, or their depression. If they've got inflammatory cytokines, he gets the cytokines down. How does he do it? He heals the gut. What does he use as a marker of intestinal permeability? LPS antibodies. Mays, M-A-E-S. You can get his papers on PubMed, M-A-E-S, Michael Mays, and you read a couple of those, you go, oh my God. And he's a really good writer. He goes step by step by step how he healed these guts in these patients, and it reverses their presenting complaints. Remember, LPS antibodies, 60,000 Daltons in size. So this is a panel, it's a blood draw that you can have done that looks for antibodies to gluten-zonulin, antibodies to actomycin, antibodies to lipopolysaccharides. This is a really nice marker to see if the patient has intestinal permeability. There's a lot of docs who say, well, I know they've got permeability because they've got Hashimoto's. Or I know they've got permeability because they've got lupus, so why don't I just heal the gut? The problem with that concept is that 6 months down the road, now the patient's feeling better, but they're not quite right yet. You say, well, let's check your gut and see how it's doing. And you find that their markers are 3-fold above the limit. And you think, gosh, I guess my protocols didn't work. And 6 months they've been taking your protocols. But the gut still has a 3-fold increased antibody level. Well, if you had checked them before you started your protocol, their gut may have been a 10-fold increase. And you're doing fabulously. You just got to tell them to stay the course. They're doing really good, but it's not healed yet. If you don't have the biomarker to start with, you're shooting in the dark. You don't know. So I recommend that you always consider doing this panel with any patients presenting with any chronic condition, because autoimmunity is the #1 cause of morbidity and mortality. And for the development of autoimmunity, it's a triad. You have to have the genetic vulnerability, an environmental trigger, and intestinal permeability. And it'll manifest as rheumatoid, or it'll manifest as MS, or it'll manifest as schizophrenia. Whatever the mechanism that it manifests as, the mechanism is intestinal permeability. This is what the test result looks like. The lab is Cyrex Labs, C-Y-R-E-X, cyrexlabs.com. And it's a great test because you now have the marker to demonstrate to the patient, here's your intestinal permeability, this is the mechanism that's contributing to the condition you have. Doc, my gut's fine, my gut doesn't hurt. I've just got my joints are all, my joints hurt. but the mechanism is coming through your intestines. So you have to educate the patient about this. You deal with symptom relief, but you got to heal the gut. For the Institute of Functional Medicine, I teach in the, we have a 5-day course called Applied Functional Medicine Clinical Practice. Anyone here gone through that? AFM-CP? No? Okay. And as you can imagine, closing your practice for 5 days is a very expensive proposition, right? And docs come from all over the world, and it sells out every time. Now it was 178 at the last one. And I'm the first person to talk to them after the welcoming. Mark Hyman welcomes them first, David Jones, the president of AFM, welcomes them second, and then I'm on stage. What do I talk to them about? Healing the gut. That's the first concept because it's the overview to everything they're going to learn in the next 5 days. The gut is primary, and I've got a gut dance. It's heal the gut, heal the gut, heal the gut. What do I do for rheumatoid? Heal the gut, heal the gut, heal the gut. What about for depression? Heal the gut, heal the gut. So I see people now, and then as I walk by, they go like this. It's critical. It's critical that you consider gut dysfunction in whatever presents to your practice if it's not acute. You know, there's some acute case, some trauma or something, of course you deal with the acute case. But if it's a chronic condition, the gut is usually the mechanism by which the manifestation has shown itself in your office. Okay. Addressing the epigenetics of intestinal permeability. How are you going to quiet the genes of inflammation? How are you going to quiet them down? Probiotics are defined as live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. Human gut communities have reinforced the key role that appropriate microbial colonization plays in gut-associated lymphoid tissue development, specific aspects of immune system development, and the integrity of the mucosal barrier. The gut microbiota help to heal the gut. They heal the intestinal epithelial barrier. Probiotics are used with the intentions to block pathogenic bacterial effects, enhance innate immunity, and stabilize intestinal epithelial homeostasis by promoting intestinal epithelial cell survival and enhancing barrier function. Look at the date. Just came out, I think it was November, in Trends in Immunology. And the title, Infection, Inflammation, and Chronic Disease, Consequences of a Modern Lifestyle. And the emphasis, and this was the 99th Dalton Conference, these are immunologists from around the world, and this is the consensus paper that came out of it. And they put a major emphasis on probiotics and the intestinal milieu, how critically important it is. And you can't just give them lactobacillus anymore. It's 1980s thinking. In some instances, the molecular mechanism of probiotic action has been conclusively demonstrated. Polysaccharide A of Bacteroides fragilis was found to be protective against experimental colitis by inducing IL-10 producing CD4 cells. IL-10 is an anti-inflammatory cytokine. It's one of the good guys. So Bacteroides fragilis, which is one of the dominant bacteria in the gut, stimulates the production of IL-10. How does it do it? It turns on the genes. Make IL-10. Make IL-10. Mechanisms of actions of gut bacteria, in terms of what we're talking about in terms of healing the gut, increase short-chain fatty acid levels. Why and how? The butyrate. For those of you not familiar with butyrate, it's the fuel for colon sites. The fastest growing cells in the body are the intestinal lining, colon sites, and they reproduce with butyrate. And if you don't have enough butyrate in your system, you make your house out of straw instead of out of brick. Thus, low butyrate levels are directly associated with colon cancer. And there are many studies on that. How do you make butyrate? You make butyrate by the action of the probiotics in the gut on vegetable fiber. That's the mechanism by which you get enough butyrate to be the fuel for your colon sites that are reproducing every 3 to 7 days. You want to produce healthier cells? You give healthier raw material. Increased barrier integrity. Gut bacteria increases barrier integrity. Gut bacteria increases immunoregulation also. Decreases tumor necrosis factor, increases secretory IgA, decreases NF-kappa B. List goes on and on of how they help. That's why the Triflora Plus is 4 different strains of pre- and probiotics. One of them is Saccharomyces boulardii, right? Which is a prebiotic. It's not a probiotic, it's a prebiotic. It helps the environment to flourish for all of the, I shouldn't say all, for most of the other normal bacteria that should be there. Saccharomyces boulardii. It also gets rid of yeast. It's an antibacterial for pathogenic bacteria. But there's 4 different strains in the Triflora Plus. The GI tract is by far the greatest user of glutamine in the body, as enterocytes and intestinal epithelium use glutamine as their principal metabolic fuel. Glutamine-enriched total parental nutrition decreases villus atrophy, increases jejunal weight, and decreases intestinal permeability. That's why there's 500 milligrams of glutamine in each of these packs, plus there's glutamine as part of the anti-inflammatory capsule that's in there that we'll talk about in a minute. The cell signaling effects of curcumin seem to be pleiotropic, as the administration of curcumin is reported to modulate a host of other cytokines and signaling pathways to produce an anti-inflammatory effect in your gut. There are so many studies on curcumin. Let's see if I think I put it in here. Yes. Look at all the different pathways from this paper from 2009 that has 300, and I think it's 340 or 350 references. Look at all the different pathways to produce an anti-inflammatory effect in the body from curcumin. We should be using curcumin in every patient. It is so pleiotropic in all the different mechanisms that it has a beneficial impact on. And look at all the different diseases. Oh, don't I have that here? Yeah. No. Where's the disease? Oh, I guess I don't have it in there. I don't know why it got lost. But there was one that showed the different diseases, of which there were 18 autoimmune diseases directly beneficially impacted by the use of curcumin. That's why the glutamine's in there as part of the anti-inflammatory caps. And curcumin is part of the anti-inflammatory that's in there. And sulforaphane glucosinates are in there, all to produce an anti-inflammatory effect, to quiet down the genes of inflammation and to increase the expression of the genes of anti-inflammation. High intestinal permeability is a normal feature of newborn gut ecology. Colostrum functions to reduce inflammation, protect against irritation from toxins, and check any potential infection, while promoting epithelial growth and repair. This combination of effects quickly reduces permeability, preventing toxins, irritants, allergens, and infectious agents from entering the body's tissues. Tom, I think it's getting a little warm in here. Maybe, is anybody warm? Mm-hmm. Yeah. Can we cool it down a bit? It might be me. I don't get that way. But
yes, you.
Yeah, I'm sure it is. Research shows that colostrum can correct this leaky gut syndrome with its unique combination of immune factors and growth stimulators, which includes epithelial growth factors. In fact, research has shown colostrum is the single most effective agent for correcting leaky gut syndrome. And for those of you that look, there are hundreds and hundreds and hundreds of papers on colostrum and its benefit in the gut. That's why this colostrum is included in this kit. For a month, maybe 2 months, we have them taking the colostrum also, because we want to heal the gut, quiet down the inflammation. Now, this particular colostrum, back up one slide, if I can. Yeah, this book just came out last year, Peptides by Dr. Andrew Keach. Andrew is a pretty amazing guy. Andrew was born and raised on a dairy farm in New Zealand. And they learn really quick. If you don't give those newborn calves colostrum in the first 3 days, they die. The calves die within a week. You can't give them milk. You got to give them colostrum. And you don't have to give them colostrum every day. You have to give them day 1 colostrum, and then maybe day 3 colostrum. Milk in between is fine. Farmers are pretty smart. They've got it all worked out. Andrew wanted to stay in this world, so he got a PhD. Do you know where he went for his PhD? Smart guy. He went to Oxford, and he got his PhD in mechanical engineering. And I said to him, Andrew, why didn't you get a degree in mechanical engineering? You're no egghead. I mean, why didn't you do that? He said, because I wanted to make the best colostrum in the world, and I had to come up with the mechanism, the equipment to do that. So he got a PhD from Oxford in mechanical engineering. And his facility is in Arizona. And they they get colostrum from over 100 small cattle ranches around that four-state area. And the rule is grass-fed only, no antibiotics for 30 days, no growth hormone ever. And a couple of ranchers apparently tried to slip in some cows that had antibiotics, and so there were some remnants of it, and he tested every batch. And when he caught it, he just canceled the contract with those ranchers. They said, oh, sorry, must have been a mistake. He said, no, you're out. And the word got out really quick, so no one tries to mess with Andrew on the supplies that they bring in. He's got a really clean product. And his manufacturing, well, we're not going to talk about it tonight, but you might talk to the vendors here that deal with this product. There's something called proline-rich polypeptides, which is one of the components in this kit that are really impressive for brain function, really, really impressive. And colostrum usually has 0.1% proline-rich polypeptides in it. Andrew's colostrum has 3 to 4% PRPs, because he came up and patented the process to make it that way. So it's organic, grass-fed, no hormones, no antibiotics, and very high in PRPs. So it's really a great product. And that's part of the gluten sensitivity kit. This is what I consider a foundation. When the gut's on fire, the body's on fire. Where it will manifest is determined by your genetic vulnerabilities and the antecedents, the things that have happened to you in life, the heavy metals that you have, the toxic chemicals, the emotional stresses that have happened in life. It just depends on where the weak link is in your chain as to where it will manifest. And how do you address this? I consider these to be the basics. The modified elimination diet, gluten-free, dairy-free. Just basic, gluten-free, dairy-free. Probiotics, colostrum, the PRPs, vitamin D, glutamine, fish oils. Oh, I forgot to talk about fish oils. Fish oils help to heal the gut. There are many studies that show that it reduces permeability, reduces inflammation in the gut. Aside from the many systemic benefits, it also has a great role to play in healing the gut. Curcumin, sulforaphane, glucosinolates. That these are the basics. And patients aren't going to open 6 or 7 bottles a day, every day, consistently, but they will take 1 pack a day. They'll take a pack a day, especially when they get it, as you do your report to them as to why it's so important to heal the gut. So the rule is, the modified elimination diet, Mrs. Patient, your gut's on fire. Stop throwing gasoline on the fire. Stop throwing gasoline on the fire. And I give them this visual. You know, if you do a charcoal grill to barbecue, you squirt charcoal lighter fluid on there, and you throw a match on the coals. Have you ever had it happen where the match didn't catch? Anyone ever have that happen? Sure. What do? You squirt more charcoal lighter fluid in there, you light another match, and you gently lay it down, and then you squirt some charcoal lighter fluid on the side, not on the match because you'll drown the flame. Squirt it on the coals, and the spray will catch to the match, and then the thing catches, right? What would happen if you had poured gasoline in there and threw a match on it? Right? That's gluten in your gut. Patients understand those kind of visuals. Use any visual you want, but help them to understand it. If they can get a picture, then they'll go along with your recommendations. You have to help them get a picture of what's going on in their body. What is celiac disease? Celiac disease was originally described as a pediatric syndrome of diarrhea, steatorrhea, and weight loss. The symptomatic presentation in which GI manifestations predominate is known as the classic presentation. Diagnosis is based on the finding of villus atrophy in the small bowel, which recovers on a gluten-free diet. This is a normal. Here it's stained for inflammation. These are all lymphocytes that have been stained. Here you've got partial villus atrophy. They're getting fatter. That's called hypertrophy. And they're shorter. And here is total villus atrophy. That's what a histology would look like. on a electromicrograph, these are the shags. This shag is where calcium is absorbed, the shag vitamin C, the shag magnesium, the fish oils, and when the shags are gone, that's what it looks like. How do you absorb calcium? These holes are where the shags were supposed to have been. How do you absorb calcium? You can't absorb anything, and you get macromolecules going right through into the intestine, and into the submucosa, and into the bloodstream. That's your patient's allergic to 25 to 30 foods. That's what villus atrophy looks like. The diagnosis of celiac disease requires, emphasis mind, the presence of small intestine mucosal villus atrophy and crypt hyperplasia. This is such a critical point. How many of you have had the experience where you tested a patient, maybe their blood work was positive, you put them on a gluten-free diet, and they started to feel better, but then they went to a gastroenterologist, got an endoscopy and histology, it came back negative, so the gastroenterologist said it's okay to eat gluten, and they went back on gluten, they feel lousy. How many of you had that experience before? Sure, bunch. But yeah, always happens, always happens. Why? Because gastroenterologists are trained that celiac disease is total villus atrophy. But you saw the studies at the beginning from the Journal of the American Medical Association that showed 39% increased mortality with total villus atrophy, 35% increased mortality with no atrophy, just positive blood work, and 72% increased mortality with just inflammation, no villus atrophy at all. So what's celiac disease? Well, according to the book, celiac disease is total villus atrophy. Anything less does not qualify. So all the numbers you hear about how many Down syndrome kids are celiacs, or how many rheumatoid patients are celiacs, all those numbers that you hear are total villus atrophy patients. Do you think it might be higher? Right? Absolutely it's higher. Absolutely. Evidence suggests that small bowel mucosal damage in celiac disease develops gradually from mucosal inflammation to crypt hyperplasia, and finally to partial and subtotal villus atrophy. Doesn't that make sense? There has to be a fire first, there has to be inflammation that's slowly causing the villi to wear down. They don't just go away one day. There's inflammation that's there, sometimes for years, before there's enough fire, enough damage, and the villi wear down. But celiac disease requires total villus atrophy, nothing less. If it's not total villus atrophy, you can't call it celiac disease. I'll show you how important that is in just a minute. It's now accepted that celiac disease may be characterized by more subtle histological changes, and some subjects only epithelial infiltration. Increase in intraepithelial lymphocytes may be present. So you can characterize it, but you can't diagnose it by more subtle histological changes. How do you diagnose celiac disease? Many cases of celiac are asymptomatic, and the gut morphological changes may be minimal, and so cannot be recognized histologically. Real problem with this clicker. The current diagnostic criteria for celiac require small bowel mucosal villus atrophy that recovers on a gluten-free diet. Clearly, the spectrum of the disease is wider. The mucosal damage develops gradually from inflammation to crypt hyperplasia and finally to villus atrophy. It is foreseen that the demonstration of small bowel mucosal villus atrophy with crypt hyperplasia will no longer be the gold standard in the diagnosis of celiac disease, when the diagnostic criteria are widened to include genetic gluten intolerance. Doesn't that make sense to you now that you know about total villus atrophy is the end stage? So it's foreseen in 2005 that it won't require total villus atrophy to get the diagnosis. Well, let's move forward to 6 weeks ago. What just came out. A long time ago, when celiac was recognized as a new disease, its diagnosis was exclusively based on the finding of villus atrophy during a small intestine biopsy. The most relevant feature of the disease was histological change, and histology became the gold standard for diagnosis. Despite substantial changes in the mode of presentation, the availability of new diagnostic tools, small bowel mucosal biopsy has remained the gold standard for celiac disease diagnosis until now. Until a few years ago, celiac disease was thought to be a rare food intolerance that was confined to childhood and characterized by severe malabsorption and flat intestinal mucosa. Currently, it's regarded as an autoimmune disorder that is common in the general population, with possible onset at any age and with many possible presentations. Identification of celiac is challenging because it can begin with extraintestinal symptoms like anemia, raised liver enzymes, osteoporosis, recurrent miscarriages, aphthous stomatitis, and associated autoimmune disorders, or it can be completely symptomless. It's evident that the old celiac disease with flat mucosa is only a part of the spectrum of celiac disease. You guys now know more than your gastroenterologist down the street about this. This just came out 6 weeks ago. The clinical presentation of celiac can be misleading because the symptoms vary tremendously from patient to patient and appear to depend largely on the length and severity of small intestine damage. The degree of villus atrophy does not correlate with symptoms, nor the mode of presentation. There is no doubt that our understanding of celiac has changed in its clinical, histological, and autoimmune features so that it seems to be a new disease as compared to that described in medical books from only 10 years ago. So if your gastroenterologist has been out in practice 10 years, his textbook's so outdated, he's thinking you need total villus atrophy, and he believes it in his heart and soul, because that's what he was taught. Therefore, it's time to change the historical dogma that uses histology as the gold standard for the detection of celiac. Alessio Fasano's at the University of Maryland, probably the top spokesman in the country for celiac disease. This is what he said just a few months ago. At our center, we did an analysis of 6,000 people. A small percent have wheat allergies, about 1%, that's IgE. Then the people who have celiac disease are 1%. Let's get that was 0.01% have IgE. Celiac disease is about 1%. What's astonishing is that the big part is the people who have gluten sensitivity. They make up 6 to 7% of the patients we see. Nationwide, that's 20 million people. And if they're sensitive to gluten, they will never go away. I was the one who said the gold standard was the biopsy. Now I'm saying I was wrong. When we say the biopsy is the gold standard, that means that it has to be there, meaning total villus atrophy. That is not really the best system. There's an array of possibilities. Perhaps in 90 out of 100 cases, the biopsy is the gold standard, but in 10 cases, the biopsy is not clear-cut. We can no longer call celiac disease a gluten-sensitive enteropathy, which means the gold standard is the biopsy. To me, it's not gold anymore. I don't even think it's silver or bronze. I believe it's copper. So, this is a critical point to get about gluten sensitivity if it's manifesting in the intestines as celiac disease. If they've got the gene and they've got positive histology, they're celiac patients. They may not have total villus atrophy yet, but they're celiac patients. Paper came out, it's not in here tonight, that if you have increased serology, you have a 40 to 50% likelihood of developing celiac disease within 7 years. If you have positive serology and you have the gene, DQ2 or DQ8, it's 100% within 7 years. We'll be doing a series of talks next year on predictive antibodies, and that's just one of them. So here's the British Medical Journal about a diagram on celiac disease. I'll back up to that for a minute. Overt celiac disease means total villus atrophy. Here's the silent ones. They've got positive serology. And these are the ones that don't seem to have positive serology or villus atrophy. This is a drawing that they did back in 1999 on this. The current ratio of clinically diagnosed to undetected cases, the size of the iceberg, is about 1 to 8. For every one you diagnose, you're going to miss 8. For every symptomatic patient with celiac, there are 8 patients with celiac and no GI symptoms. You can't think about celiac with GI symptoms. You have to think about celiac with disease. Wherever the genetic weak link is, that's where it may manifest. Not GI. Only 1 out of 8 manifests GI. So if you think GI for celiac disease, then you will successfully identify 12.5% of those that come in. Because they'll have total villus atrophy, they'll have the symptoms that are classic for celiac disease. And you will miss 87.5% of them. That's 1 in 8. So let's test. How do you test for gluten sensitivity with or without celiac disease? How do you look at this? These are the blood tests that are out there now. Endomysium is the saran wrap around the microvilli and around muscle and other tissue. Transglutaminase is an enzyme inside endomysium, and it's a more sensitive marker than endomysium. So most doctors are using transglutaminase nowadays. Gliadin is one of the peptides of the gluten molecule in wheat. And 2 years ago, Mayo Clinic came out and said, we're not checking gliadin anymore, we're going to do deamidated gliadin because it's more sensitive for celiac disease. And it is. It's more sensitive for celiac disease. It is not more sensitive for gluten sensitivity. It's more sensitive for celiac disease. So that would be 1 out of 8. Right? Serum IgA, endomysium, and transglutaminase antibodies are powerful tools in disclosing celiac disease with overt villus atrophy. Powerful tools. What's the key word there? Overt. Overt. Remember above the waterline? Overt. Seronegative celiac disease occurs. Antibody positivity correlates with more severe villus atrophy and not the mode of presentation. Okay, got that. Recent literature showed that blood tests, not only endomysium but also transglutaminase, seems to be ineffective in detecting most of the patients affected by subclinical or silent disease. The blood tests are ineffective. These are the false negatives that you're getting. One study evaluating endomysial antibodies showed the sensitivity of this marker was 100% in patients with total villus atrophy, but the value plummeted to 31% in patients with partial villus atrophy. They're very accurate tests for celiac disease. Very accurate. But remember, the definition of celiac disease is total villus atrophy. And they're very accurate tests for that. But if you don't have total villus atrophy, you're going to miss it most of the time. Antibodies of transglutaminase likewise correlate with the degree of villus atrophy. Patients with non-villus atrophy gluten sensitivity are more likely to test negative for transglutaminase and endomysium. Patients with classical disease and total villus atrophy were endomysial positive 77% of the time, whereas those with classical disease and partial villus atrophy were endomysial positive 24% of the time. So the message is the current testing is right on the money if you have total villus atrophy. If you don't have total villus atrophy, you're only going to successfully identify total villus atrophy, and you're likely to miss partial villus atrophy or just the increase in IELs, the inflammation that's the most dangerous. More people die from that. You'll miss it completely. It's up to 7 out of 10 times. Using the tests that every laboratory uses. Endomysium, transglutaminase, and gliadin, or deamidated gliadin. You'll miss it most of the time. 1 out of 8 have total villus atrophy, the rest don't. These blood tests are right on the money if you have total villus atrophy. This is why it's been such a, I call it the conundrum of gluten sensitivity. You do a blood test, it comes back negative, you convince your patient to go on a gluten-free diet anyway, they feel better, their symptoms go away. How's that possible? It's the blood test, it was wrong. It should have come back positive, but it was the wrong test. Gluten is the protein fraction of most cereals, including wheat, rye, and barley. It's comprised of hundreds of protein components, traditionally classified on the basis of their solubility in alcohol or water. Analysis of the gluten proteome has led to the identification of as many as 60 peptides of gluten that trigger an immune response. 60! This is how I say it to the patients. Think of protein like a brick wall. Digestion is getting the mortar off of the bricks, in between each brick. So one brick gets laid down, and then you get the mortar off of the next brick, you get the mortar up. And these bricks, they can go right through the shags and into the submucosa in the bloodstream. That's absorption of amino acids. So think of each brick as an amino acid. Digestion breaks down proteins into individual amino acids, or maybe 2 amino acids together, called a dipeptide. Now, imagine this brick wall, this protein, and someone just takes a sledgehammer and goes, boom, and breaks up the wall. Now you've got clumps of bricks, maybe 33 bricks, and 17 bricks, and 11 bricks, and 12 bricks. Those are called the peptides of gluten. There are over 60 of these peptides that they found that trigger an immune response. But we only look for gliadin, the 33 amino acid. The identification of the toxic gluten peptides provides new opportunities to screen. This may help to prevent disease development in individuals at risk. Here's an example in this study, in the Journal of Immunology. They took these celiac patients and they looked at a number of the peptides of gluten and to see what was the immune system reacting to. This one here is a 33 brick alpha-gliadin. That's the one that every lab checks, alpha-gliadin. But the top half of this study, these patients came back negative. These are the people whose blood tests would come back negative if you're looking for gliadin. They're responding to something else. But every lab in the country only looks at gliadin. There's no reason why. Some of the papers I have, they go back, they started talking about this in 1999. That there are multiple peptides of gluten that may be triggered in celiac disease. This is before they ever thought of gluten sensitivity. The 33-mer is a very potent peptide. We confirmed the prominent stimulatory capacity of this peptide. This is gliadin. It's prominent. Most of the people respond to it. Up to 50% do. But that means 50% don't. We found that 50% of these patients do not respond to the alpha-gliadin peptide, but to a diverse set of gliadin and glutenin peptides. The diversity of the gluten-specific T-cell response is far greater than was previously appreciated. Both adult and young celiac patients can respond to a diverse repertoire of gluten peptides. Here's another study. These are all the celiac patients. These are different peptides they looked at. It's hard to find two that had the same response. They're all different. We're unique. You know, and there's a theme that we're using next year. You know, like what's your fingerprint identifies you. We're going to be talking about your immune print. What's your immune print? No one's ever thought about this before. We just think about white blood cells and maybe cytokines. And, yeah, everybody's got cytokines. Well, but if you weren't breastfed, your gut may be thinking that Clostridium is normal for you. And you've had a Clostridium infection your entire life. Right? What's your immune print? What's your immune system saying? Although some patients respond to one set of peptides, others respond to different sets of peptides. Interestingly, the 17-mer, the 25-mer, the 18-mer, and 13-mer were just as potent as the 33. Just as potent. This study for the first time demonstrates that next to gliadin-derived antigens, glutenin-derived peptides are involved in gluten-specific T-cell responses. Look at the date. 1999. How come no lab has picked up on this? I don't know. I don't know the answer to that. These glutenin-specific T cells may, like gliadin-specific T cells, contribute to disease pathogenesis by the secretion of large amounts of interferon gamma. We found 50% of these patients do not respond to alpha-gliadin, but to a diverse set of gliadin and glutenin peptides. Further characterization of the antibody specificity revealed preferential reactivity towards different gluten proteins. Oh, I put this one in here. It just came out in May of last year. Because here, novel immune response to gluten in individuals with schizophrenia. What did they find? Schizophrenics don't respond to alpha-gliadin. They don't have antibodies to alpha-gliadin. They have antibodies to other peptides. And they found that 46% of the schizophrenics patients in this study had antibodies to different peptides of gluten. 46% of them. And they said when they got gluten on their diet, almost, I don't remember the number, but almost every one of them got better. Reduced medication or off the medication. Read the study in Schizophrenic Research, 2010. It's unbelievable. And I threw this one in here just to show that different peptides may impact on different parts of our body. This is an emerging field no one really knows right now. The peptide antibody assay has higher diagnostic accuracy than just anti-gliadin antibodies for distinguishing patients with celiac from controls. The identification of the toxic gluten peptides provides new opportunities to screen. And here's a blood test that is now available looking at 10 different peptides of gluten. There's a 33-mer. So it looks at 10, and it also looks at transglutaminase and GAD65. Why GAD65? GAD65, one of its functions as an enzyme is it is the rate-limiting enzyme in the conversion of glutamine to glutamate to GABA, our major neuroinhibitory transmitter. So if you have antibodies to GAD65, you likely will have a GABA deficiency. Here comes anxiety. and depression, actually, both sides of it. So we threw that in there because we thought it'd probably be high in a lot of people, and it is. It's looking about 30% of the people that come back positive to one of the peptides of gluten have elevated GAD65. About 30%. How many people here know or suspect that you have a sensitivity to gluten? Show of hands, please. High. Hold your hand up for a minute. Look around the room. Thank you. Now, keep your hands up for a minute, if you would, please. How many of you know or suspect if you have an exposure to gluten seems to affect your brain? Keep your hands up. Look around the room. This is your practice. This is your practice. This is GAD65. And there's many others, but that's why we put that in there. This is Cyrex Labs. This is called their array panel number 3, gluten sensitivity 12 peptide panel. Why don't people feel like $1 million on a gluten-free diet? And why is mortality increased 3-fold for children diagnosed with celiac disease? One of the reasons is, one mechanism is cross-reactivity. What is cross-reactivity? The phenomenon of immunologic cross-reactivity occurs when an adaptive immune response to one antigen, like your body makes antibodies against gluten, results in reactivity to structurally related antigens. Although antigen-antibody reactions are highly specific, in some cases antibodies elicited by one antigen can cross-react with an unrelated antigen. Are there foods with a cross-reactive immune response to gluten? Yes, there are. A role of cross-reactivity in food allergies was reported as early as 1942, with the recognition that individuals sensitized to pollen allergens were more likely to exhibit allergic symptoms upon eating certain fruits. Back up. Having a hard time. A mucosal inflammatory response, similar to that elicited by gluten, was produced by cow's milk protein in about 50% of the patients with celiac disease. Casein in particular seems to be involved. This is why we never recommend a gluten-free diet. We recommend gluten and dairy-free, at least as a minimum. You start there. Gluten and dairy. Celiac disease and cow's milk protein enteropathy cause damage to the proximal mucosa. And it's a question of which came first, the chicken or the egg. If you don't check the genes, you don't know. I'm not sure it matters. You take gluten and dairy out of their diets together. Amino acid sequences with a high degree of identity to the toxic peptides of gluten were detected in corn, oats, rice, yeast, chicken muscles, as well as beta-casein and galanin. Now what's galanin? Galanin is a neuropeptide widely expressed in the brain. So if you cross-react galanin with gluten, meaning you got antibodies to gluten, you might get antibodies to galanin. Look at what galanin does. Galanin is predominantly involved in the modulation and inhibition of action potentials in neurons. Do you think that might be something to avoid, is interrupting action potential in neurons? Galanin has been implicated in many biologically diverse functions, including nociception, waking and sleep regulation, cognition, feeding, regulation of moods, regulation of blood pressure. It also has roles in development as well as acting as a trophic factor. Galanin is a critical component to all nerve function. You have antibodies to gluten, you might make antibodies to galanin. Galanin is linked to a number of diseases, including Alzheimer's, epilepsy, depression, eating disorders, and cancer. It appears to have neuroprotective activity as its biosynthesis is increased 2 to 10-fold upon axonomy in the peripheral nervous system, as well as when seizure activity occurs in the brain. It may also promote neurogenesis. It's really a good guy. But when you have a problem with galanin, like an autoimmune response attacking galanin, it may manifest in any neurological symptom. And that's why when you put your patients on gluten-free diets, the darndest things turn around. Their vision gets better, their brain functions better, their hearing gets better, their tinnitus goes away, their seizures go away. You know, 50% of children with drug-resistant epilepsy, imagine drug-resistant epilepsy. You're the parent of a child with drug-resistant epilepsy. That means you've been to 3 neurologists maybe, tried a number of medications, nothing's working. 50% of these kids go in complete remission on a gluten-free diet. 50%. Journal of Gastroenterology, 2007. 50% of them. One of the most common lifelong disorders in the country. Cross-reactivity requires that the antibody combining site has shape complementary complementarity with both the linear epitope and the peptide. What does that mean? I like the visuals. Here's the visual. This is the antibody to gliadin. I like to think of it as a spaceship coming into a docking station. You know how the spaceship's got the long nose in the front, and the docking station's this big saucer cup, and just kind of glides into that saucer cup, right? That's how I think about antigens and antibodies. And gliadin fits right into the gliadin antibody, just locks right in there. Well, here's casein from dairy. It has shape complementarity with gliadin so that it fits in there well enough to lock into the locking station. Excuse me. And the result is it activates gliadin antibodies. And I couldn't find any literature of pea protein having anything to do with shape similarity or cross-reacting with gliadin. Let's look at casein antibodies. Casein antibodies, casein locks right in there completely. Islet cell antibodies from the pancreas. This is why you've heard that you don't give dairy to a newborn for the first year if they're at high risk for type 1 diabetes. There's a family history of type 1 diabetes, you don't give them dairy. Why? Because they'll make antibodies to the dairy, and it has cross-reactivity with islet cells, and you fuel the development of type 1 diabetes in these kids. That's why you don't give them dairy, because it's a cross-reactivity with islet cells. Even minute traces of gliadin, or their cross-reactive foods, are capable of triggering a state of heightened immune activity in gluten-sensitive people. So here's the amino acid sequences of similarity between celiac and transglutaminase, between celiac and heat shock proteins, between celiac and myotubular-related protein, and between celiac and toll-like receptors. So the amino acids are similar. That's why they lock in to those docking stations so easily. And here is the test from Cyrex that looks for cross-reactive foods. Now the first ones I'll show you are the ones that directly cross-react with gluten. All the dairy, milk chocolate, yeast, oats, and coffee. So if you have a celiac patient or a gluten-sensitive patient, if they have a sensitivity to coffee, they're not going to get better, because the immune system will keep making antibodies to gluten. And the inflammation continues. They maintain the intestinal permeability because the inflammation, the intestinal permeability allows macromolecules to come through, and systemic inflammation. And wherever their weak link is, that's the autoimmune mechanism that gets activated. This causes this, causes this, causes this, causes that. The next group are the ones that are directly associated with wheat. And that is, oh, I guess not. Okay. Oh, let me back that up. Yeah, the ones that are directly associated with wheat. There they are. Rye, barley, Polish wheat, and spelt. They're directly associated with it. The next group are the foods that are recommended to people on a gluten-free diet. Sesame, hemp, sorghum, millet, amaranth, quinoa, buckwheat, tapioca. Well, what's wrong with that? You never developed oral tolerance to amaranth when you were an infant. What happens when you eat amaranth 3, 4, 5 times a week every week? You don't have oral tolerance. Oral tolerance is done by the age of, I asked that PhD down in Sao Paulo last Friday. I said, when does oral tolerance finish? He said, by the age of 12. By the age of 12. So if you didn't have amaranth or quinoa as a child, you really don't want to recommend, or to your patients, you don't want to recommend that they eat it regularly, quinoa cereal. It's okay to have it, but you don't want to keep taking it in there every day, because the immune system eventually is going to say, wait a minute, this is not good for me. This is an overload here. Right? And then the last ones are things that are often increased on a gluten-free diet: corn, rice, and potatoes. Nothing wrong with corn, rice, and potatoes unless you have a sensitivity to corn or rice or potatoes. But when you eat it every day, twice a day, 3 times a day, it can become a problem. Right? So this is array number 4 from Cyrex Labs to look for cross-reactivity. I don't think it's safe anymore to recommend a gluten-free diet without doing array number 4. I haven't found a patient yet that came positive on 3, meaning peptides of gluten, who didn't have some of these positive on 4. I haven't found one yet. I've probably done, I don't know, maybe 75, maybe 100 patients in the last year with these new tests. I haven't found one yet. Yes?
So if they show positive for several of these, are you telling them that they can't have that for life?
That's a really good question, and the answer is no one knows yet, because this is so new a concept. However, let me ask you, have we forgotten about memory B cells? This whole thing about a rotation diet, I've got to tell you, there's no science behind it. It's all anecdotal, rotation diets. There's no science. I've never found anything that validates it. No one's ever checked for antibodies to corn. Once you're rotating corn every 4 days, you're allergic to corn, you get off corn for a while, then you go back and eat corn every once in a while, it doesn't seem to be a problem, you're okay with it. No one's ever looked to see if there are antibodies to corn. Memory B cells don't go away. Your immune system makes memory B cells to fight whatever it's going to fight. They don't go away. How do we think we can fool the immune system? There's a technique out there called Naroomba, N-A-E-T, right? Anyone practitioners of that?
N-A-E-T.
N-A-E-T, yeah. And they are really, it's a successful technique to getting rid of the symptoms related to different sensitivities, cats, dander, foods. My problem is that these practitioners then say it's okay to eat the food. Did you ever check to see if the antibodies went away? No one's ever checked. And I've challenged them. I said, you got the money, you've got thousands of practitioners following this technique, do the study. Get 100 patients. Do the full antibody panels beforehand, do your techniques, wait 6 months, do the antibody panels again. Keep them off the food, or not, but recheck. They won't do the studies. They won't do the studies. That's the only way you know for sure. And if the immune system quiets down, then you've really got something that the whole world should know about, right? But until you do that, I now think it's malpractice to tell people it's okay to eat that food again, knowing this is the #1 cause of morbidity and mortality in the industrialized world, is intestinal permeability causing systemic inflammation. Wherever the genetic weak link is, that's where you're going down. I think it's malpractice. And I'll stand on any stage and say that. Yes, sorry.
What role do digestive enzymes play on maybe decreasing gut permeability